Summary of immunobullous diseases. Quick summary of immunobullous diseases. First, we will talk about the epidermal immune bullous disease and non-immune bullous diseases, the epidermal and subepidermal types, and also we will talk about the pathogenesis, the immunopathogenesis, and the treatment. Here, the bullous diseases are either immunobullous or non-immunobullous. The immunobullous diseases, which are intraepidermal bully pemphigus group, pemphigus vulgaris, vegetans, foliaceus, and erythematosus, induced pemphigus, immunoglobulin A pemphigus, and paraneoplastic pemphigus. The subepidermal bully, which is the group of bullous pemphigoid, cicatricial pemphigoid, herpes gestationis, and epidermolysis bullosa acquisita, bullous systemic lupus, DH, and linear immunoglobulin A dermatosis, chronic bullous disease of childhood, and also the non-bullous dermatosis, non-immune bullous dermatosis, which epidermolysis bullosa congenita, subcorneal posterior dermatosis, Haley disease. Now, for the histopathology, they're all either the here there is the pemphigus group, which is intraepidermal bully. Okay, the subepidermal bully, either subepidermal bully with eosinophils like bullous pemphigoid, cicatricial pemphigoid, and herpes gestationis, and with subepidermal bully with neutrophils like epidermolysis bullosa acquisita, bullous systemic lupus, DH, and lab and chronic bullous disease of childhood. There is also subepidermal bully with lymphocytes like bullous lichen planus, and with mast cell like bullous mastocytosis. This is for differential, and with no infiltrate like congenital epidermolysis bullosa. And we will talk also about the pathogenesis of the bullous diseases. They are all in the pemphigus. There is binding of immunoglobulin of antibodies antibodies to the adhesion molecules, either desmoglein 3 or 1 or desmoglein 1, leading to loss of cell-to-cell adhesion, leading to acantholysis. They are all the same. Binding of antibodies to the adhesion molecules lead to loss of cell-to-cell adhesion, leads to acantholysis. In subepidermal bully, there is binding of antibodies to their target molecules, leading to influx of inflammatory cells, which are either eosinophils or neutrophils, with subsequent release of hydrolytic enzymes, leading to digestion of cell matrix adhesion and blister formation. This is the pathogenesis. What about the immunohistochemistry? Direct immunofluorescence and indirect immunofluorescence for all bullous diseases. The direct immunofluorescence, immunoglobulin G in complement 3 in pemphigus along keratinocyte membrane, and in bullous pemphigoid and cicatricial pemphigoid, herpes gestationis, epidermolysis bullosa acquisita, and bullous systemic lupus, they are linear deposition of in basement membrane zone. So in pemphigus along keratinocyte membrane, intracellular and intercellular, and in the this group there is linear deposition of basement membrane zone. Immunoglobulin G and complement 3. What about immunoglobulin A dermatosis? There is of course deposition of immunoglobulin A, granular deposit at dermal papillae in DH, lab and chronic bullous disease of childhood. There is linear deposition in basement membrane zone. This is the direct immunofluorescence. What about indirect immunofluorescence? There is circulating immunoglobulin G antibodies in pemphigus against desmosomal catechoreins, and for the others, there is circulating immunoglobulin G1-4 in bullous pemphigoid, cicatricial pemphigoid, herpes gestationis against bullous pemphigoid antigen in dermoepidermal junction in the roof, and in epidermolysis bullosa and bullous systemic lupus, they're against collagen 7 in sublamina densa in the base. So there is circulating immunoglobulin G antibody G1 and G2 in pemphigus against desmosomal catechoreins. In others, against dermoepidermal junction in the these in the first group in the against bullous pemphigoid antigen in dermoepidermal junction at the roof, and the others in against collagen 7 in sublamina densa in the base. For immunoglobulin A dermatosis, there is circulating immunoglobulin A antibodies against. Of course, the DH is negative. There's no circulating antibodies against DH. And for lead and chronic bullous disease of childhood, there is circulating immunoglobulin A against basement membrane zone antibodies. It's positive in 30% in adult and 80% in child, of course, in the roof of the bully. For the treatment, there is treatment of immunobullous diseases. There is the pemphigus group and the bullous pemphigoid group. For the pemphigus group, we give large doses of systemic steroid as immunosuppressive, and also some other like azathioprine, cyclosporin, methotrexate, and Cellcept, and these things and cyclophosphamide. These as we give as adjuvant therapy. And for the treatment of bullous pemphigoid group, we give anti-inflammatory drugs. So we give low doses of steroids and also dapsone, tetracycline, and nicotinamide. So as treatment of pemphigus vulgaris group, we give high dose of steroid, and there is some steroid sparing as azathioprine, cyclophosphamide, cyclophenolate, mofetil, Cellcept, methotrexate, and cyclosporin A. For the details, like we said, prednisolone 1 milligram per kilogram per day, and or pulse therapy or intralesional therapy. And also there is for pemphigus foliaceus and mild disease, we give topical, and systemic, we give also systemic steroid, sometimes with or without steroid sparing agent as dapsone, gold, and azathioprine. Immunoglobulin A pemphigus, of course, A pemphigus we give dapsone 100 mg daily is the drug of the choice. Paraneoplastic pemphigus, we treat the pemphigus and the cancer. The pemphigus we give prednisone 40 to 60 mg per day, cyclosporin with or without cyclosporin A 5 mg per kilogram per day, and we make excision of the treatment of the underlying neoplasm, especially the benign one. For the other subepidermal bully, we give low doses of steroid, dapsone, tetracycline, and nicotinamide. For the whole bullous pemphigoid and sclerosis pemphigoid, herpes gestationis, and also the epidermolysis bullosa acquisita and bullous systemic lupus. For the immunobullous immunoglobulin A dermatosis, we give, of course, dapsone. It's the drug of a choice, and sulfonamides and alternative. Here there is a comment: dapsone responsive bullous diseases. The diseases we give dapsone in dermatology. We have the epidermolysis bullosa acquisita and bullous systemic lupus erythematosus, immunoglobulin A pemphigus, DH labbed and chronic bullous disease of childhood, and we also give in subcorneal posterior dermatosis and also another disease, not bullous, which is the leprosy. This is the dapsone responsive bullous dermatosis. And here we end the bullous diseases.